Well, maybe let's get started. Then probably some more will call in. Welcome everybody to the November edition of the CMR Journal Club on this day where many of us probably still recover from the changes in politics, but I don't want to get on that one. Today's topic is MR in hypertrophic cardiomyopathy, and we have two very interesting papers. And we'll get started with a meta-analysis that was published in JACC Imaging very recently. And it's from the team of Karamitsos and Apostolos Kiaos. Both are from the University of Thessaloniki in Greece. Will present the results of this meta-analysis, and I would ask Apostolos to share his screen and walk us through the PDF. As usual, we try to present the paper within 10 minutes just by walking through the PDF. Then we have some time to discuss. And and hopefully we'll all learn from that. So Apostolos, take it from here. We do not see your screen yet.
1 second.
Yeah, looks
Can you see now my screen?
Not yet. It just says...
Okay. Hello, everyone.
Now we see it. Everything's good. Okay, thanks. Go ahead.
Okay. Hello, everyone. Thank you for the invitation and the opportunity to participate in this webinar. So the article that I will present is a meta-analysis for the prognostic value of quantitative LGE in predicting sudden cardiac death in hypertrophic cardiomyopathy. We all know that the LG extent is a well-established risk factor of sudden cardiac death in hypertrophic cardiomyopathy. However, it is not clear how we should use it in daily clinical practice. The American guidelines provide a weak class 2B recommendation that in the absence of other risk factors, extensive fibrosis on cardiac MRI may be considered as an indication for ICD. The European guidelines have not included LGE in the 5-year risk score, and similarly with the American guidelines, they provide weak recommendation class 2B that for low-risk patients, LG more than 15% may be considered as an indication for ICD. The reasons for this
I don't know, is it just me or are we losing connection? Okay, so the international connection doesn't seem to be very good. Apostolos, can you try to improve your internet connection maybe by closing other applications on your computer that may affect your connection? Okay, so we may have lost that. Apostolos, could you try to, if you can hear us, if you could try to improve your connection or maybe switch off your video. So I stopped the video for him, but okay. I think in the interest of time, we should maybe continue with the other article and wait for Apostolos to come back. So Dr. Nakamoria, would you be able to share your screen and present?
Okay, sure. I'm ready.
Okay, can you share?
So, before we begin, may I confirm that we are able to share the screen slide?
Yeah, we can see it. Great, thank you.
Okay. So, good afternoon, everyone. Today's I'll be discussing the progression, the late enhancement in the hypertrophic cardiomyopathy patient, and how age affects this progression. So this topic is crucial for understanding how we can better assess sudden cardiac death risk and optimize the clinical management in this patient population. As many of you know, sudden cardiac death is one of the most devastating outcomes in patients with HCM. Unfortunately, we have effective strategy for preventing sudden cardiac death, primarily through the use of ICD in high-risk patients. The latest 2020 ACC/AHA guidelines identified late enhancement of 15% or more of the left ventricular mass as a significant risk factor for sudden cardiac death. The late enhancement represent area of fibrosis, and these scarred regions are often responsible for life-threatening ventricular arrhythmia. However, despite its importance, there's limited data on how late enhancement changes over time, particularly in relation to the age and how this progression might influence decision about ICD implantation and repeat imaging. So today, I'll be presenting our study. I'll examine the progression late enhancement in the HCM patient, especially how age affects this progression, and whether serial CMR scan are necessary to track late enhancement changes over time. So, let me begin the study design. We look at 100 to 8 patients from two major academic medical centers. So Beth Israel Deaconess Medical Center and Tufts Medical Center. So these patients were referred for cardiac MRI scan between the 2008-2019. The diagnosis of the HCM was confirmed by left ventricular hypertrophy, defined as a wall thickness of 15 millimeters or greater. Each patient underwent at least 2 CMR scans, so initial scan and the follow-up scan, with an average interval 3.7 years. At the beginning of the study, we also assessed the standard sudden cardiac risk factors, such as family history, unexplained syncope, and of course, the presence of late enhancement. So our primary aim was measure how late enhancement progressed over time and whether age influenced this progression. So in terms of the imaging, here, the CMR scan was performed at 1.5T over 3T MR machines. We used gadolinium contrast to highlight area of the fibrosis and then calculate the percentage of late enhancement in the left ventricle. The late enhancement analysis was done by experienced readers who were blinded to the patient outcomes, and the fibrosis was defined as area with a signal intensity 6 standard deviation above the normal myocardium. So now on to the result. The study showed that 60% of the patient had late enhancement present at the baseline, occupying around the 4.8% their left ventricular mass. So over time, this late enhancement increased in the 87% of those patients, reaching average of the 7.7% by the time of the follow-up scan. So interestingly, 25 patients who initially had no late enhancement developed new late enhancement during the study period. So which means that by end of the study, 84% of patient had a measurable fibrosis. The rate of the late enhancement progression was a 0.7% per year on the average, but we found 21% patients showed accelerated progression of 1% or more per year. So now here is where age becomes the important factor. When we stratified the patient by age, we found the patient under 60 years were 4 times more likely to have accelerated late enhancement progression than those over the 60 years. In fact, 25 patients of under 60 years had the late enhancement progression rate greater than 1% per year, compared to the just 7% of the patient age 60 and above. This suggests the younger patient, particularly those under 60 years, are much higher risk of the fibrotic progression, which could elevate their risk for ventricular arrhythmia and consequently sudden cardiac death. Then move to the discussion. These figures show the representative cases. So these findings are important for a few reasons. The first, they confirm HCM is a progressive disease, especially in younger to middle-aged adults, while we already knew our rate of enhancement increased over time. So this is the first study to our knowledge showing the rate of enhancement progress first in the patient under 60 years. The second, accelerated fibrotic progression we observed in the younger patient may help explain the higher overall mortality risk in seen in younger patient diagnosed with HCM. They're increasing the scar tissue in the myocardium can disrupt the heart electrical signal, potentially triggered lethal arrhythmias. So this highlights the need to closely monitor younger HCM patients for changes in rate enhancement. So in practice, this means that we should consider repeating the CMR scan every 5 years. So particularly in those under 60 years to re-evaluate for rate enhancement progression. So for example, the patient rate enhancement may increase from the 10% to the 15% over the 5 years period. So potentially placing them in the higher risk category and changing their management plan, including whether ICD implantation should be considered. Additionally, we found the moderate correlation between the rate enhancement progression and LV mass and wall thickness, which suggests the CMR and the imaging technique could be useful for tracking the ventricular changes in patients with renal dysfunction who may not tolerate repeat the gadolinium-based contrast agents. So now it is important to acknowledge the limitation of our study. So this was a retrospective study and with relatively small sample size and the variable time interval between the CMR scans could have influence our findings. So despite these limitations, our study data provided strong evidence about 25% HCM patient under 60 years showed a rapid rate of enhancement progression. So this emphasizes the need for age-stratified management and suggests the younger patient should undergo more frequent CMR scan to assess the rate of enhancement changes over time. Finally, we believe the prospective large multicenter study are needed to determine the optimal scan intervals and further explore the relationship between the rate of enhancement progression and the sudden cardiac risk in the younger HCM patients. Thank you for your attention. I'm happy to take any questions.
Thank you very much for the clear presentation of this interesting data. As usual, if you have questions, please post them in the chat or just unmute yourself and speak up. I have 2 quick questions. One is, and I may have missed that, did you analyze which one was the more important factor? Was it the age or was it the progression So I know that the progression was correlated with the age, but was one of them the more important marker eventually? Or, I mean, the conclusion, should it be that all young patients should be considered high risk, or predominantly young patients with a progression that is observed?
We focus on the LZ progression. So it's related to age, but so the maybe sorry, please say it again your question.
Yeah, so I was just wondering, so you say here, and thanks for showing that on the risk was higher in patients when they were young, and the risk of progression, and it was in the young people. So does it mean that just the age is a risk factor, or does it, and the older patients have a different phenotype of hypertrophic cardiomyopathy that is not as severe, so that just in young or what was the additional value of the progression for outcomes?
Yes, maybe I think so. The age is associated with the later enhancement progression, but the age is also important. But the age is associated with the genetic mutation. But so the later enhancement is also the very important factor that beyond the age.
Yeah. Okay. No, I get.
Comment on that, Mathias.
Yeah.
I think number of subjects here is very low to make anything connect age to the outcome. And then you have a survival bias here. The patients who are older survive the disease for a longer time. So it's really hard to try to distinguish if it's age related to the outcome or no. I think it can only show you there is a more progression at the younger age than the older subject. I don't think it's easy to connect that to the outcome.
Yeah, okay. And Victor Ferrari has a comment related to that, or a question that the retrospective nature of the study may introduce indeed a bias, basically a survival bias just by the follow-up, that a clinical event or a suspicion of disease progression could have triggered a second scan and therefore created an apparent high risk. So do you want to comment on that as well?
Yes, there is some bias there, but I don't think we monitor the patient more frequently based on age at this level.
Yeah.
So yeah, there is some intrinsic bias into that. Vic is correct.
Yeah. And then there was another question by Andrea Barizon. Was there a difference in the LGE rate and the progression, so the progression between septal and apical hypertrophic cardiomyopathy? Were you able to differentiate these two groups?
We didn't look at that. I don't think we have enough to be able to distinguish the two.
Yeah. And then a final last question from myself. Can you say how many of these had was formally considered typical for hypertrophic cardiomyopathy, the LGE at the septal insertion points of the right ventricle?
So in the study, we include the insertion point later enhancement.
Okay, so was that the predominant feature or the predominant appearance, the insertion fibrosis, or was it more diffuse or elsewhere?
Most patients are more diffuse, but so including the insertion point and later enhancement.
Okay, because I think the insertion fibrosis is interesting because this probably reflects the additional stress caused by the right ventricular insertion on hypertrophied areas, and I think they yeah. Okay, thank you very much. In the interest of time, sorry, Tavri, you have your hand raised. Just ask her, just unmute yourself.
I've unmuted myself. Can I speak?
Yes, yes.
Can you hear me?
Yes, we can hear you.
Yeah, I am Dr. Om Tauri from Mumbai, India. And I had an opportunity to start first MRI with Charles Higgins way back 85, 87.
Oh,
I
okay.
have one queries here. After last 5 years, we have been seeing very young people getting the acute attack problem, and most of them are having not more than that non-ischemic cardiomyopathy. And I follow with them the quantification of the ejection fraction, which is very high, especially hypertrophic cardiomyopathy. So do you grade this hypertrophic cardiomyopathy according to the quantification, mild, moderate, or severe, that may help in the prognosis, apart from the enhancement pattern for fibrosis? This I want to know. I've seen a lot of younger people.
So the question is, would you grade hypertrophic cardiomyopathy as
Yeah.
moderate or
Nobody
severe
suggests here.
based
My
on-
thinking
yeah.
is this.
Yeah, but so you want to grade it concerning the prognosis or yeah,
Correct.
not
Right.
the-
These patients.
Okay, I think that's an interesting suggestion. And then so please continue the discussion here in the chat, because we have to move on to the next paper, and Dr. Nezafata has already agreed. So I would now ask Apostolos again to share your screen and walk us through your meta-analysis of the late enhancement in patients with hypertrophic cardiomyopathy. Let's hope the internet will hold.
Okay, hello again.
Yeah.
Should I start from the beginning? I don't know at which point the connection.
Just speed up and start from the beginning.
Okay. So the article I will present is a meta-analysis for the prognostic value of quantitative LGE in predicting sudden cardiac death in hypertrophic cardiomyopathy.
Don't see your shared screen though yet, just so you know. Yeah, now it's seems
Okay.
okay. Yeah, okay. So
Okay, so we all know that LG extent is a well-established risk factor for predicting sudden cardiac death in hypertrophic cardiomyopathy, but it is not clear how we should use it in daily clinical practice. And the reasons for this lack of evidence for proper use are that there are different methods of LG quantification, and we don't know which is the best. And also, it is not clear which is the optimal LG cutoff that should be used. So the purpose of this study was to identify the optimal way to use quantitative LG in hypertrophic cardiomyopathy. This meta-analysis has included patients with hypertrophic cardiomyopathy who had a cardiac MRI, and LG was expressed as percentage of left ventricular mass. The primary outcome was sudden cardiac death or aborted sudden cardiac death. In total, 11 studies were included with 5,550 patients, and the median follow-up time was 5.2 years. The sudden cardiac death event rate was 4.4%. The first finding of this meta-analysis was that, as expected, LG extent was a good predictor of sudden cardiac death in hypertrophic cardiomyopathy. As we can see in this figure, odds ratio was 4.93, and the 95% confidence interval was 3.75 to 6.47. But this is something that we knew, that the LG extent is a good predictor of sudden cardiac death. The important finding here is that the LG extent is far from being a perfect marker, because a perfect marker should have odds ratio more than 10. Therefore, this means that the LG extent should only be used in combination with other risk factors for predicting sudden cardiac death. Another finding of this meta-analysis was that the different LG quantification techniques have similar accuracy in predicting sudden cardiac death in hypertrophic cardiomyopathy. We can see here there were data for manual quantification, the 6, the 4, and the 2 standard deviation techniques, and the p-value was 0.443. We can also see in this table that the most extensively studied technique was the 6 standard deviation technique. We can see that 7 studies used this technique. And therefore, it was possible only for this technique to calculate sensitivity and specificity across different thresholds. We can see in this table sensitivity and specificity for the thresholds LG 5, 10, 15, and 20%. I'm repeating, these numbers are only for the 6 standard deviation technique. We can see from this table that the LG 10% is the threshold with the highest sum of sensitivity and specificity. Then it is 15%, and both of them have higher sum than 20 and 5%. To validate further this result, a direct comparison was made between LG 10% and LG 15%. And this comparison showed that 10% is statistically superior to 15%. We can see here that p-value was 0.014. Also, from this graph, we can see that studies which used LG 10% as cutoff are closer to the top left corner of the graph compared to the studies which used 15%. And this also suggests that 10% has higher accuracy because the closer to the top left corner, the higher the accuracy. So in summary, this meta-analysis shows LG extent is not a perfect marker. It should only be used in combination with other risk markers. And also it shows that there is no statistically significant difference among the different quantification techniques, but the 6 standard deviation technique has been studied more extensively. And for this technique, LG 10% is the threshold which has the highest sum of sensitivity and specificity. Finally, I want to make a comment about the limitation of the study. You might be thinking that although we have time to event data, we have used odds ratio and not hazard ratio. Indeed, this is a limitation. However, a recently published study suggested that odds ratio is an acceptable alternative to hazard ratio when we have low event probabilities, which is the case for the sudden cardiac death in hypertrophic cardiomyopathy. So we cannot use odds ratio when we have, for example, a cancer with high mortality, but it is acceptable to use it when we have low event probabilities. Thank you very much. I don't know if you have...
Thank you very much. Fantastic, very concise and interesting. So I think your takeaways are important messages. And although, as you said, maybe some data are still lacking regarding various analysis methods, but it's a very good evidence that 10% cutoff makes a lot of sense. And for the time being, the 6 standard deviations probably is a good way to look at that. And while it's not perfect, as you said, it is definitely a very strong and maybe yet underestimated predictor of sudden death. So, Dr. Tavri, you have a question? Just unmute yourself.
Shiro, can you hear me?
Yes.
Yeah, I just wanted to ask you, when there is a lot of patients where I get just patchy enhancement in the RV insertion point, and what do you think of the prognosis there? Just patchy enhancement at the RV-SCM, we call it with the thickness SCM or HOCM. So how do you rate them for the prognosis? Nothing else in the enhancement except the patchy RV insertion.
The question is, what? Yeah, if it's isolated late gadolinium enhancement around the RV insertion, how do you
rate prognosis again? How do you
regarding the prognostic value? Dr.
Sorry, the question is if there is only RV insertion point.
Yeah, if it's only
exactly. I see a lot patients. SCM. Their thickness is not about 15 to 17, 18 millimeter, the interseptal thickness, but the ejection fraction is 70, 75. But do you see RV insertion point? So we call it definitely SCM, or if it is SAM is there, then we call it HOCM. But what is the prognosis when there's just patchy enhancement, this patient? What do you feel about that?
I think just focusing on the LG, if someone has only in RV ratio points, the total percentage will be low. So
We come across a lot young here. I do a lot studies in India, so we come across. So I just like to know more prognosis rather than infiltrative disorder or other fibrosis. That is what my.
I guess the answer was that if it's only the RV insertion, the percentage would not be very high, and therefore the prognostic value.
Yes, so I guess focusing only on the LG, I don't know for the other parameters, the percentage will be low, so it should be better than someone who has a higher percentage.
Okay, so I have actually a follow-up question on that. No, but first, quickly, and then we have to wrap up soon. Do you think we need more studies looking at two standard deviations? Because you said we do not have enough studies, but the odds ratio that you described was much higher, actually over more than 10 as compared to the 60. Do you think we need more prospective studies on that?
Because there was no statistically significant difference, although odds ratio. Just 1 second.
Okay, and
we can see. I don't know if you can see the screen. We can see, although it was 10, the odds ratio, we can see that the confidence, the 95% confidence interval is very large. So I guess if there are more studies, I'm not sure that it will be close to 10, but probably it would help to clarify this. Yes.
Yeah, now I understand the confidence interval currently does not allow to say it's better, but it may be. So that's why it may. So do you, last question and then we have to wrap up. Are there other, so if you see the value of late gadolinium enhancement, and of course no clinician would only take the late gadolinium enhancement alone. So what are your thoughts on, I mean, previously we used 30 millimeters septal thickness. And there's also, there may be other markers coming from the MRI, such as strain. So do you think there are other markers that should be used in combination with late enhancement so that we can use an MRI as a powerful predictor, not only because of the late gadolinium enhancement, but also with other markers? Or do you think the contribution of MRI is mostly the late gadolinium enhancement?
Of course, there are other markers. We know well-established markers. We know that for the aneurysm, for example, that we might not see in echo, we can calculate the thickness better. So definitely MRI is not only for late gadolinium enhancement.
Yeah. Okay. Thank you very much, both of you. So I think we learned a lot on hypertrophic cardiomyopathy, not only on what it can do, but also where we may need some more data. With that, I want to thank both of you for the presentation and the others for the contributions, for the discussion. We'll see you back in December, on December 4th. I will post the program soon for the next journal club then on the first Wednesday in December, as I said, December 4th. And until then, I wish everybody a good recovery of the recent events and a good fall. Yeah, see you then. All the best, everybody. Bye-bye.
Bye-bye.